side. We're basically going to show you how research has helped us in our clinical practice on a day-to-day basis. We have 6 speakers. Dr. Rohit is at his session. He'll finish it and come. So I will start with the session and hand it over to Dr. Naresh. My topic is on intraoperative OCT and how it has helped us. We know that OCT imaging has revolutionized imaging ocular structures and the various disease conditions. However, it has only very recently found its way into the surgical theatre. Early attempts have been there to use a dismantled machine and also using the handheld bioptician, but not really integrating it into the operating microscope. So we now have the microscope integrated OCT, which is a seamless high-resolution real-time imaging of the surgical maneuvers right from the incision to the wound closure. So here it has helped us in the visualization of the instruments, and also of the intraoperative tissue manipulation is also possible using this in vivo modality. The previous devices usually lacked the true coaxiality, but hence it was always very difficult to focus. But this has overcome that disadvantage. So we have used the RESCAN 700, which is one of the first microscope integrated OCT or the MIOCT systems. Which has been used clinically to visualize steps. This is mounted on a OPMI Lumira 700 and uses the Resight lens system. These are some of the technical details of the machine. So going on to the actual clinical applications of it in retina first. It has helped us right from imaging the wound construction to the wound closure. So you can see the anatomical configuration of scleral entry wounds being uniplanar in 25 gauge and biplanar in 23 gauge, and also the wound apposition after removal of the trocar can also be confirmed. As you can see here, you can see the sclerotomy closure here with edematous edges after the removal of a 23 gauge trocar. So in proliferative retinopathy, it has helped us in initiating delamination and segmentation of membranes. It also helps in identifying a safe plane to initiate the membrane peeling in cases of diffuse or plastered tractional retinal detachments. So this has actually helped us in reducing the risk of damage to underlying tissues. At the end of surgery, it also helps us to see if any residual traction exists or for the adequacy of membrane peeling. So if you see here, you can see the broad-based adhesions with bridging retinal tissue. So in these conditions, it's really useful to initiate the desegmentation. Here also it has helped us by looking at the membranes to see whether membrane peeling has been adequate. Vitreous hemorrhage is one other condition where it's extremely useful because preoperatively you are unable to assess the macular status. So during surgery, once you finish clearing the vitreous hemorrhage, you can assess the macula for edema or if there are any membranes present. In cases of VMT, it helps us to look at the strength of the adhesions. Also decreases the risk of de-roofing because you're able to visualize the surgical process in toto. It also helps in complete removal of the ERM and the ILM and prevents inadvertent grasping of the retina. Therefore, you can avoid retinal tears and breaks. So here you can see the extent of the VMT can be assessed intraoperatively quite well. Going on to foveoschisis, multiple staining processes can be avoided because you can actually confirm intraoperatively that no posterior hyaloid has been left behind. Also, it allows us to better assess the ILM because patients with high myopia have a really long axial and sometimes it's difficult during surgery. And since the myopic retinae are thinner, iatrogenic breaks can be prevented because it allows better visualization. Also, since there are multiple layers of schisis in these patients, we need to keep repeatedly staining them. So each layer as it is removed, it can be well visualized. So this is an intraoperative picture of a myopic schisis and can be imaged despite the longer axial lens. Going on to macular hole, here inadvertent NFL touches or breaks can be avoided, therefore can avoid positive scotomas that can occur. It may also be possible to do away with dyes again in these patients because you can actually see the scroll of the ILM as you're peeling it. In cases of failed or previous macular hole surgeries, you can see the edge of the peeled ILM and also possible to observe the opposition of the edges of the hole once the membrane peeling has been converted. So if you see here, you will see the scroll of the peeled ILM. This is a patient intraoperative of cystoid macular edema with lamellar macular hole. In patients with retinal detachment, it's possible to see help us during induction of the PVD to see if there's any residual SRF that's present, and also for completion of fluid air exchange. It can also detect the presence of PVR and the rolled edges of the retinal breaks. So here you can see we have imaged the edge of retinal break here with the rolled edges. So during pars plana lensectomy, it's also possible to monitor the anterior capsule while doing the lensectomy. So in case we have the anterior capsule retained, we can always place the IOL at a later stage or at the same setting. Potential uses in ROP include to see the depth of any preretinal membranes, also to see what are the tractional elements that are there, and also to image any flat neovascular fronts in vascular retinopathies. Just want to add a little bit on clinical applications in anterior segment. So here again it's possible to look at the entry wound. Here it's done with a keratome, and this is using the femtolaser assisted cataract surgery. This is before the opening of the wound. So you can clearly visualize the wound margins. Here this is the post IOL implantation. If you see that the wound is still not completely closed, whereas post hydration you can see that the wound is closed and opposed. So for Capsulorhexis, as we all know, during femtolaser assisted, part of the anterior cortical also is included while you're doing the rhexis, whereas if you during a regular MICS, just the capsule you see here is lifted up. This is an interesting video. This is an intumescent cataract. So just after the anterior capsule is ruptured, you will see here the rupture is happening. You will see the liquid cortical matter escaping. Okay, so in posterior polar cataract, there's an interesting thing in that we can differentiate whether there is an actual posterior polar or a posterior subcapsular. So if you see in the ASOCT here, it appears like it is actually a posterior polar, but when you image it here intraoperatively, you see that there's a clear space. So that goes more in favor of a posterior subcapsular. Whereas if you see in this case, this is a clear-cut posterior polar cataract. So when you see a clear space here, this is offering us a higher resolution, therefore an advantage of having to be able to differentiate between posterior polar and a posterior subcapsular. So it becomes easy to plan your hydro and your further course of steps for cataract surgery. It also helps you to look at the sutures and find out the correct depth of the trench while doing your phaco surgery. It's also useful to image where the IOL is placed in the bag. Just play the video. So I think as far as I'm not very well versed with these, but from what I've been taught about it is that the toric IOLs I think need to be placed posterior, as close to the posterior capsule as possible. So here it will actually allow you can see if this is the IOL and you can see the capsule just below it. There's a lot of gap between the two. So this is the posterior capsule and this is the lens. So you'll actually be able to determine the position of the IOL after the surgery. And this is one last video on its use during corneal surgeries. It can be used for DALK. So coming to some of the drawbacks, targeting the OCT field of view to the area of interest is sometimes difficult. Also, there are no inbuilt calipers as of now, and the visualization of the instrument in the underlying retina can be affected by the optical properties of the surgical instruments. So these can actually cause obscuration due to back shadowing. So metallic instruments, here you can see the back shadowing. Metallic instruments like forceps and needles have a very high reflectivity, and these cause total shadowing below the instrument, whereas silicone instruments have moderate reflectivity with minimal shadowing. So in conclusion, the MIOCT has a potential to transfer OCT from a research tool to a surgical assistive device. You can achieve a greater understanding of the intraoperative retinal morphological changes by observing the instrument and tissue interaction, and it can also help prognosticate surgical outcomes more objectively. Thank you.